Good morning, respected teachers, seniors, and my dear colleagues. Today I am about to present a case about a patient, 39-year-old male patient, who presented to us with SOP on exertion since last 6 months with intermittent right-sided chest pain for the same duration. The history of present illness goes about like he was apparently well 6 months back. We started having intermittent SOB on exertion and right-sided chest pain, which was insidious in onset, sharp in character, occurring during inspiration. He was admitted at Murshidabad Medical College and ICD was given on right side in October 2023. The pleural fluid study then reported as straw-colored lymphocytic transurethral ADA 10.6, AFP negative, GSCS no growth, M cells negative. There was a repeated admission at same college in the month of February 2024. Again, ICD was given, repositioning was done twice, and he was started on clinico-radiological basis on 15th Feb in view of recurrent pleural effusion. No history of fever, cough, expectoration, hemoptysis, or pulmonary tuberculosis. In the past, he was diagnosed with chronic pancreatitis 2 years back. He received treatment at Hyderabad for the same, and he was still on regular treatment because of no symptomatic relief yet. He was non-hypertensive, non-diabetic, and there is no known thyroid disorder. Drug history, he was taking ATD since 15th Feb. On admission, it was ATD day 36. And he also received supportive treatment in view of chronic pancreatitis. Sleep appetite were normal, bladder bowel habits were normal. He was ex-alcoholic. He had quit alcohol 2 years back. He was a current smoker. There is no significant family history. General survey points were within normal limits. There was no pallor, cyanosis, icterus, edema, clubbing or lymphadenopathy. JVP was not raised. Neck veins not engorged. Neck glands not palpable. Pulse 82 per minute. BP 136 by 80. Saturation was 98% at room air. Respiratory rate 16 per minute and CBG 136 milligram per dm. And patient was afebrile. As per the systemic examination, we started with respiratory system. Upper respiratory tract examination was within normal limits. Lower respiratory tract examination on inspection revealed shape to be normal without any visible thoracic deformity. Movement of chest was normal, no evidence of any respiratory distress. Apical impulse was located over 5th intercostal space at midclavicular line. There was no venous prominence, no localized or generalized fullness or depression, no wheezing or stridor, no intercostal suction. Skin over front, back and sides of chest appears to be normal. There was a scar mark of the previous ICD at right triangle of safety. The surface temperature on palpation was normal. Tenderness was present at the ICD scar site. There was no chest asymmetry. Possession of trachea and apex beat were normal. Bilateral symmetrical movement of chest was seen with respiration. Vocal fremitus was decreased over right mammary, axillary, intra-axillary, interscapular and infrascapular area. On percussion, dullness was noted anteriorly along 4th, 5th, 6th intercostal spaces along the midclavicular line, laterally along the 4th, 5th, 6th, 7th, 8th intercostal spaces along the mid-axillary line, and posteriorly along the interscapular area over 3rd, 4th, 5th, 6th intercostal space and infrascapular area over the 7th and 8th intercostal space. On auscultation, we found reduced VVS in the right mammary, axillary, intra-axillary, interscapular and infrascapular areas. Vocal resonance was reduced over the similar regions and there was no adventitious sounds heard. On gastrointestinal system examination, upper GI tract, oral cavity and oropharynx were within normal limits. Abdomen on inspection, condition of skin was normal. All quadrants were moving with respiration. No localized swelling. On palpation, abdomen was soft. No tenderness present. Surface temperature is normal. Percussion was tympanitic. Upper border of liver dullness couldn't be delineated. Auscultation, peristaltic sounds were present. CVS and CNS examinations were within normal limits. My provisional diagnosis was right-sided pleural effusion. He presented with a previous report of a HRCT thorax, but he didn't have any CT plates. The report read as patchy consolidation, septal and fissural thickening in partially collapsed right lung and right pleural thickening with hydropneumothorax. This is a previous X-ray done in the month of February, which showed right-sided pleural effusion with ICD in situ. And this is the X-ray in the month of February, which again shows right middle and lower zone opacity, probably due to effusion. The investigation findings done at our place were blood parameters were within normal limits. Sputum AFB was negative. Sputum culture showed E. coli. Serology was non-reactive. PTA-PTT INR was within normal limit. USG whole abdomen showed grade 1 hepatomegaly. Chest X-ray on admission showed right middle and lower zone opacity with a small pocket of hydropneumothorax, probably iatrogenic. USG screening was done and encysted pleural effusion was noted. Diagnostic aspiration was done. Brown colored fluid was aspirated. The pleural fluid analysis showed brown colored fluid, cell count 24,821, polymorphonuclear, exudative, ADA 20.2, CBNAT not detected, GSCS showed no growth, M cells negative. Looked probably like empyema. Chest X-ray after few days showed decrease in amount of pleural fluid because therapeutic aspiration was also done. Showed heterogeneous opacification in the middle zone with lower zone dense homogeneous opacity with obliteration of CP angle, and diaphragm over the right side could not be traced. The serum amylase lipase levels were moderately elevated. Pleural fluid amylase and lipase values were very high, amylase being 4,162 and lipase being 2,690. Further, we planned for CCT thorax and whole abdomen. The CCT scan of the patient showed an encysted large pleural effusion along with peripancreatic fluid collection. This is the effusion, encysted effusion, and it is connecting with peripancreatic fluid via the esophageal hiatus. CCT report read as pancreas atrophied with relative sparing of tail, multiple intraductal and intraparenchymal calcifications noted with resultant irregular dilatation of main pancreatic duct measuring around 6 to 7 mm, possibility of changes of chronic pancreatitis. An elongated peripherally enhancing organized collection was noted in peripancreatic region at the tail, which extends cranially and medially towards esophageal hiatus and appears to pass in mediastinal space, possibly via esophageal hiatus. Approx craniocaudal extent of collection measures 8 cm. Within mediastinal space, it extends for about 4 to 5 cm. Mediastinal component of collection possibly communicates with right pleural space via mediastinal pleura, and resultant mild right-sided pleural effusion was noted. Findings were suggestive of possibility of pancreaticopleural fistula. Patient was managed conservatively with IV antibiotics, and ATD was stopped after seeing the CCT reports. Therapeutic aspiration was done, 350 ml of fluid aspirated. General surgery opinion taken, they asked for CTVS opinion and asked to review after discharge for bypass surgery. As per CTVS opinion, they said it was encysted pleural effusion, then they asked to review after 2 weeks with a fresh chest X-ray. Gastroenterology opinion was taken. They said there is probably a pancreatic pseudocyst with pancreaticopleural fistula. They advised for USG or CT guided drainage of encysted pleural effusion, USG or CT guided drainage of percutaneous drainage of organized peripancreatic collection around pancreatic tail, and they advised capsule pancreatin 25,000 TDS with meals and tablet multivitamin with L-methionine and selenium BD to continue. Final diagnosis was pancreaticopleural fistula with encysted pleural effusion. Pancreaticopleural fistula causes pleural effusion, which is extremely unusual, accounting for less than 1% of cases. It is seen in 3 to 7% of patients with pancreatitis, and a combined frequency of internal pancreatic fistula, that's pancreatic ascites, and the pancreaticopleural fistula is seen between 0.4 and 7% of chronic pancreatitis patients. and in 6 and 14% of patients with pseudocyst. Pancreaticopleural fistula, however, are more unusual than the pancreatic ascites. It usually presents as large recurrent pleural effusion, being predominantly more common in left side. Right-sided and bilateral pleural effusions occur in 19 and 14% of patients respectively. The development is usually as a consequence of leak from an incompletely formed or ruptured pseudocyst, or in a minority of cases due to direct pancreatic duct leak. The fistulous tract passes either through the aortic or esophageal diaphragmatic orifice or directly transdiaphragmatically. The major complication in these patients is superinfection, which contributes to significant morbidity and mortality. Available treatment modalities now include conservative or medical management with octreotide and regular thoracocentesis. Octreotide is given as an initial dose of 50 microgram, administered subcutaneously thrice, and the dose is titrated based on the output of the fistula, maximum dose being employed as 250 micrograms 3 times daily. ERCP plus minus endoscopic pancreatic stent is next possible modality of treatment. And final is the surgical treatment, which includes either some form of a pancreatic resection or enteropancreatic anastomosis to the site of pancreatic duct leakage or to the pseudocyst.